This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast. Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors. A place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. Today we are joined by Dr. John McGill, who is a urologist specializing in robotic surgery at Phoebe Urology in Albany, Georgia. He received his training at Northwestern University's Feinberg School of Medicine, the Cleveland Clinic, and Case Medical Center in Cleveland, Ohio. He has over 15 years of experience in urinary conditions, including kidney stone removal. In addition to his clinical work as a urologist, Dr. McGill is an active advocate for the dissemination of life-saving information about prostate cancer. His advocacy includes being chair of the R. Frank Jones Urological Society's Community Prostate Health Fair, which is a series of regional events held in conjunction with the American Medical Association. These prostate health fairs go into communities to connect people with resources that they may not be aware of, including healthcare professionals, free PSA screenings, research institutions, hospitals, and more. Dr. McGill joins us today to further his work in making a difference in health disparities within the medical community. Elle and Shay, take it away.
Thank you for that great introduction, Dennis, as usual. Shay and I are really excited about welcoming Dr. John McGill here. Hi, Shay. How are you? Let me greet my wife. Hello, Shay.
Hi, Elle. I'm good. How are you?
Good. So, Dr. McGill, we're really pleased to have you with us today.
Yes.
We had a great introduction by Dennis, but we'd like to hear a little bit about your background from you. So if you could kind of give us, from your perspective, your background and what made you decide to become a doctor, and specifically focusing on the area of urology. How did you come to decide that future for yourself?
Sure. I wanted to start by saying I appreciate the opportunity. It's a pleasure, again, to see you, Elle, after our event in June. Mm-hmm. Shay and Dennis, it's nice to meet you.
You as well.
So I'm Dr. John McGill. I'm originally from Chicago, specifically born in Harvey, Illinois. I went to Northwestern undergrad, Northwestern Med. I went to Case Western for my surgical training, and I did a research fellowship in andrology at the Cleveland Clinic. I was keenly focused on research, basic, translational, and clinical. And I woke up one day and said, I want to get in the community. And I've been there since. I am in Albany, Georgia now, and have had opportunities to lead within the community that have led me into what we'll talk about a little later with the Black Urology Society, R. Frank Jones Urological Society, and some of our screening events and things. My interest in medicine actually started when I was 4.
Wow.
I was 4. I went to a free health clinic, and I had a provider that was not Black, that was extremely rude to me, to my mother. He took a needle and jammed it in my arm really hard and chased me all around the room. And I was so distraught. I walked out of the room and I looked in his waiting room and it was all Black people. And I said, I bet I can do what he does. And after that, the rest was history. I didn't want to do anything else. So it's interesting how these things happen. I went from there and I just committed my academics to going into medicine because I wanted to make a difference. I wanted to have an interaction that was different from that, from my patients. So that was how I made my decision. My specific decision for urology was based out of a few things. Number one, I had two uncles with prostate cancer. And prior to going into medical school, I had one that was told he was getting active surveillance, and another one was told he needed to get seeds. Now, as a Black person, I'm immediately thinking somebody's lying, because how is he getting one treatment and the other one's getting another treatment? We need to get the one brother over to the other brother's doctor. But I didn't understand the nuances and the differences between the types of prostate cancer, and I'll do that later. That was what got my eye interested. And then at Northwestern has a very strong urology program, and they are very, very education focused.
Yes.
And mentoring is important. And some of these principles I take into my own leadership opportunities now, particularly at the national level. And I'm thankful to them for that. They did a wonderful job of kind of shepherding me through the process and helping me as I grew up in urology. And so that was that. They gave us research opportunities, which you don't always get as a student. They gave me opportunities within the operating room and even within the community. We did some screenings at the Bull Stadium with a couple of the doctors. And so it was good. It was good. And so that's kind of how I got into urology. I would say I was less than nurtured initially, but I was nurtured in the end.
Okay. So you mentioned that you had this experience as a child, and that led you to become a urologist. And you also mentioned that, many of you had some family members that were prostate cancer survivors. So I want to explore this issue about the prevalence or the benefit of having a Black or people of color, a doctor of color, treating men. A lot of times guys are reluctant to go to the doctor and whatnot. Do you feel that being a doctor of color, a Black doctor, that you will have a beneficial impact on making men, in particular Black men, more comfortable in pursuing, looking after their prostate condition?
Well, that's a great question, Al. As I mentioned before, and as you astutely tied in, my initial experience kind of played a very significant role in how I view my role as a provider. I think that as a Black physician, it is natural for me to be sensitive to social determinants of health, social issues, communication related issues, things like that. Not that there aren't non-Black providers that, have mastered that. And I'm in no way saying that. But I do think that in order to be successful as a Black physician, that is an important component of it. And I would make the argument that God is blessed I've been successful. I think that some things folks think are not advantages, I see as advantages. I see it as an advantage. Unfortunately, despite the fact that, the Black American population is approximately 14% of the U.S. population, it's only approximately 2% of urologists. And so we've got a lot of work there. But in the interim, those of us that are in leadership in particular have to kind of stand in the gap and kind of hold the line, so to speak. And part of that is leading from the front and compassion. And like, we had mentioned in a previous conversation, sometimes people come in and they don't want to talk about urology initially. You have to give them that space to open up, and understanding that if you don't allow them to talk about what's top of mind, they're definitely not going to open up about sexual issues.
Yes.
And so you've got to allow them to let it, organically develop and let it be what it's going to be. And so I think there are some advantages to it. I'm a firm believer that the pain is part of the process. And I'm thankful for the experiences that I had as a patient, because it has helped me, I believe, to connect better with the population.
So you mentioned that you're in Albany, Georgia, and you went there, I know, from one of the previous discussions that you and I had, that you went there in order to take an opportunity to start a robotic surgery center there. So let's talk about robotic surgery versus the older conventional surgery.
So robotics versus open. Robotics has grown tremendously over the last 20, 25 years. I would argue, and most surgeons would argue, it's the standard of care now. It is not common to see open prostatectomies or open prostate procedures, not as common. There are some instances where that is appropriate, but that is few and far between and much less prevalent than what we would have expected 20 years ago. Typically, the places where you're seeing more open are places where they either do not have a robot or where the surgeon is not robotically trained. That's typically where you're seeing that. There are some instances where the surgeon is robotically trained and chooses to go open, but that's kind of a case-by-case medical decision. But again, that is rare. Robotics has been a very significant advance in surgery in general, let alone in prostate surgery. There's less pain involved with it, shorter hospital stays. Some argue shorter catheterization times. And so there's plenty of benefits to robotics. When that's you on the table, you want to go home.
Right.
You don't want to be in the hospital 4 and 5 days watching the urine. Is it pink? Is it red? Are there clots? And so we typically don't see that. There are actually some places where they're doing robotic surgeries and sending folks home the same day. That's how far we've come with that procedure. And so I think, particularly in a situation where you're at centers of excellence where they're doing a lot of them, it's a very safe and I would say standard procedure as far as prostate cancer is concerned.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
So, Dr. McGill, welcome to the show. We're so happy to have you. So I want to follow up with that. So during robotic surgery, it is my understanding that the nerves around the prostate are disturbed. Is that correct? Okay. So can you explain to me, and I'm very curious about this because we talked to a lot of guys, and even Elle initially had a few months of this. So when those nerves are disturbed, why is it that, some men have longer lasting, incontinent? And then some guys even have, we've been told, and we've, had guys on the show and we've interviewed guys that they have lasting ED. So what happens when those nerves are disturbed that would cause this?
So that's a great question. So typically with a prostate surgery, when we're thinking about the nerves, we're thinking about the nerves that help with erectile function, that lay intimately toward the bottom and the sides of the prostate. And those kind of have to be pushed out of the way to be preserved. Now, unfortunately, during surgery, sometimes they have to be removed in order to make sure we get all the cancer out. And sometimes those nerves, for lack of a better word, can kind of go into a bit of a shock where they kind of just go to sleep for a while and they take some time to come back around. A lot of that is dependent upon the surgeon, the aggressiveness and location of the cancer as well. And so, and even more importantly, what is the man's sexual function prior to coming into that surgery? So what I tell people is, if it wasn't going great before, it's not going to be better after. Typically, you're going to take a bit of a hit, and then you may start to see some improvement over time. We don't fully know until about a year, but usually after a few months, we kind of have an idea where that person's going to be. We give meds and we have different options to try to support during that time. But it's important to know anybody that's looking at that kind of procedure that typically you're gonna take a hit. Most men will take a hit at least for a period of time, not necessarily indefinitely. As far as incontinence is concerned,
now that was the thing that Elle had for a few months. That and we were like, hey, wait, what's going on here?
And that's great you brought that up. About 90% of men will have incontinence after the catheter comes out. So it's not common to have the catheter out and be fully continent. And so it's important to discuss that. That's part of the expectation. And it's usually a rough ride those first 2 or 3 months. It's usually a rough ride. And then it'll start to settle in. And again, very similar to erectile function, you won't fully know until you're at about a year. But after a few months, you kind of have an idea where we're at. But it's to be expected. The body's gone through you may have had very small incisions, but it was a very, very, very traumatic reconstructive procedure that's going on inside. And so the body kind of has to settle and heal and get accustomed to the new anatomy. And so it just takes a little bit of time.
Yeah. And I want listeners to know there is therapy for that. I wasn't aware of that, but Elle went to like physical therapies for it. And honey, what was it? And it actually strengthened. Honey, explain it.
So Dr. McGill can address the muscle impact that it has, but there is a muscle that helps control your urine function. The best example I could use is that if you laugh or you sneeze, there's leakage that occurs, and there's a muscle that's impacted by the surgical procedure. And then, after your surgery, there's a physical rehabilitation that you can engage in, and you can go to, a rehabilitation center or an area that specializes in physical therapy. They'll send you through a series of exercises and whatnot, and they'll teach you how to strengthen that muscle and control it. And that will help a man get better control of his leakage.
So you are correct. So there's a muscle called the external urethral sphincter, which
I was going to say that.
Yes, I know you were. I was reading your mind, brother. The external urethral sphincter. And the way I describe it, like you said, when you cough, you sneeze, the way I describe it is if you were a kid and you were peeing somewhere you weren't supposed to pee, that muscle that you would tense to stop, that's the muscle. Mm-hmm. Men are not as in tune with their bodies, so to speak, in that area. And so women, we tend to not have as much difficulty teaching what we call Kegels, where you learn to build that muscle up just like any other muscle in the body to get it stronger. But you're right, the physical therapy component can be very helpful. There are even some places where they have you start that before surgery to make sure that muscle is kind of built up and ready for the surgery. And so that is an important part, I believe, of the healing process, not only of the body, but of the mind, because it can be kind of rough to keep changing pads and diapers, and it can be kind of daunting. Nobody, wants to have to think about that as they move on through their day-to-day life, but knowing that there's a light at the end of the tunnel can be reassuring. So I want to make sure that our listeners know that typically this is something that gets better with time post-surgery.
Yes, exactly. It does.
Okay, so I want to circle back to a point that we discussed a few minutes ago, and that is the sexual impact that the prostate surgery will have on a guy. And the fact that some guys have heard about this impact that it has on their sexual capabilities, and they will forego prostate surgery or prostate treatment because they don't want to lose any of their sexual function. But one of the things that, we always say is that people that are sick, and particularly people that may pass away from a disease, they can't have sex. So, you're making a life and death decision with that. I'd like for you to address the importance of that decision.
I am so glad you said that. I say almost the exact same thing, except I just say dead men can't have sex.
I was trying to be delicate.
Yeah, but I think at this time you got to dive in, man, because
yeah, exactly.
I find that whenever you start on anything related to the prostate, you have to lead with the sexual function, because that's going to be your number one challenge. So I come from a sales background as well. So in between college and undergrad, I did a little bit of sales. So a lot of times I'll walk in and I'm thinking, all right, what are going to be some of the number one detractions? What are going to be my challenges in this? And number one is always sex, even if they don't say it.
Yes.
And so I try to make sure that we have a comfortable relationship where that person is able to explore and to ask questions the way they need to ask. And so I think that's an important part, number one. Number two, I think reassurance is important. In a person like that, you try to get them linked up with maybe another survivor, somebody who's done well. People tend to find whatever supports what they already believe. And so I try to find a patient who may have done very well, who can answer the questions, not from a medical standpoint, but as a patient. And I think sometimes that helps. I've had men run from that too. I've had them run from that. And a lot of it, I think, is how well can you connect? You don't always get that right. You don't always get that connection, but I think it's worth trying. The importance of sex cannot be in this conversation cannot be overstated, is what I'm overly saying. But to anyone that's listening, to make that decision based on that alone, knowing that we have pills, knowing that we have procedures, knowing that we have surgeries that can get a man back in the game, I think is a little short-sighted. We want to make sure that we know that although you may not be what you were when you were 19, it doesn't necessarily mean that the game is over.
Exactly. And I always tell the listeners that if they're going to make that decision, to have surgery, I'm just honest and I just say, hey, get as much sex in as you can pre-surgery, because Elle and I, that's once he was diagnosed and we decided to make the decision for him to have the surgery. We knew about this. So it was almost like, what are we having for breakfast? Sex. What are we having for lunch? Sex. What are we having for dinner? Sex. Sex was breakfast, lunch, and dinner. We got as much in as we could because we understood that post-surgery, it would be a while. So I'm just like, hey, get it in, because the reality of the situation is it's going to be a while before you're back in the game.
I think that's very wise. And it is wonderful having a partner that understands. I think that it's important that whoever is going through decision making as far as surgery versus radiation versus other treatment options, having the partner involved is important because those conversations need to be had together, whether, it's an egalitarian process or not, however they manage that relationship. But I think it's worth having that partner there because you don't want to be alone in this process.
And that's really, really great that you mentioned that, Dr. McGill, because, we've had family counselors on and Dr. Kitson Francis out of Huntsville, Alabama, calls it the symptom sharer and the symptom bearer, and then the symptom sharer, because this is a couple's disease. And, thank God I'm blessed with a great understanding wife, a great partner, and we've gone through this together. So I want to transition here to the R. Frank Jones Urological Society, which is what led to our meeting each other, Dr. McGill. Can you talk to us a little bit about the R. Frank Jones Society and the work that you guys do, and what is it and why does it exist? Give us an overview of that organization.
So I am the director of community engagement for the R. Frank Jones Urological Society, which is the Black Urology Society in the United States. We are the urology arm of the National Medical Association, which is the Black Physician Association. And a couple years ago, our president at that time, Dr. Linda McIntyre out of Michigan, had decided that she was frustrated with the fact that we would have these really nice meetings. We would bring Black physicians from all over the country, really all over the world, to a city. And we'd have a, great education, a big party, catch up, and we would leave nothing for the community. And so her vision was to make sure that every time we left the community, we left it a little better, a little more educated, that a little more engaged with their own resources in that area. And she saw that as what we should be doing, not only at the National Medical Association meetings, but also at the American Urological Association meetings, which is our larger governing body. We didn't get as strong a support at the AUA level at that time, but the NMA said, well, yeah, we support it. And so last year we started in July in New Orleans and started a campaign where we would go into churches.
Last year was what year?
I'm sorry, that's July of 2023.
Okay.
We went into churches and we partnered with pharmaceutical companies, the American Cancer Society, Tulane University, and basically brought high-level, cutting-edge information into the church and turned the church into I would say, a research meeting with a backyard barbecue feel.
Okay.
If that makes sense.
It does.
So coming from Northwestern, education and information is very important to me. As I mentioned before, with my experience as a Black patient, how you disseminate that is very important. And so what we do is we take top shelf information and top shelf physicians, and we bring them into the church, and we're wearing polo shirts and jeans. We're not wearing three-piece suits. Mm-hmm. A person may be grabbing a sandwich at the event and not realize they're talking to one of the foremost leaders in urology and asking them, what should I do about this diagnosis? What should I do about this PSA? And so we go in with a mindset of we want to screen people. But it's more than that. It's to raise awareness. It's to create a safe space for men. And what I find is that there are many men who are already diagnosed and at different points in their journey who either have had a significant pause and whether they were going to move forward on their treatment or just stop following up, or were struggling or suffering through the sequelae related to a treatment. And doing that in silence because they didn't feel like there was a safe place or a place where someone could listen to them about sexual function, about urinary incontinence, about the fact that their grandkid won't sit on their lap because they smell like urine all the time, things like that. So these are very real things that affect quality of life that we want to create spaces where our community is able to discuss and to grow and to heal. And so we started in New Orleans, and we moved on from there and went to, we try to do it at different national meetings. So the American Society of Clinical Oncology had a cancer meeting in Chicago in June, and Elle was gracious enough to join us. And so we enjoyed having you there, and I enjoyed meeting you there. And we had one in Harlem about, 9 days ago as well at the National Medical Association with a plan to come back to Chicago actually for the National Medical Association meeting next July. And so that's what we focus on as far as community outreach. And we have other things we work on. We also work with R. Frank Jones on increasing the number of Black urologists. It's important. We need to encourage our students. As I mentioned, we only make up 2% of all urologists. There's a large gap there. And so we need to encourage our students. And the ways we do that are by bringing them into spaces where they're able to do research and become more competitive as medical students, things like that, and other mentoring opportunities. And so usually with those meetings, those screening dates on those conferences, or at those conferences, we have a mentoring reception the same day. And so those are all tied together.
Don't forget to subscribe to our YouTube channel and like this video to keep seeing more content like this from us. It will also benefit YouTube's algorithm, helping to introduce our content to others who may need it most.
Okay. So you mentioned that we had met in Chicago, and that was a really great event. A couple things stood out in my mind about the event. Number one, there was a great panel of urologists that had actually flown in from different parts of the country to be on that panel, and I was a part of that, which I felt, really honored to be on a panel with such a distinguished list of doctors and achievers in the prostate cancer area. But also it was like you said, a real social feel to it. There were barbers there giving free haircuts. There was a great lunch that was brought in. And the other thing that really stood out in my mind was the great prizes. A lot of times you go to these things and they'll give you a little, plastic fries and stuff, but they were giving away like barbecue grills. I mean, they were giving us some real gifts there. So it was a great event, and looking forward to getting back into the Chicago area where we are.
Dr. McGill, so what is the response when you're talking to the participant, the people that show up for these events in terms of PSA screening? Because I tell the listeners all the time, I am a true firm believer in PSA screenings, because I totally know that that's what saved my husband, the PSA screening and, prevention and going on a regular basis. I think my husband went every 6 months, for his screening. And that's how we caught, the numbers kept going up, and that's how he ended up with a biopsy and then subsequently diagnosed with prostate cancer. So I'm a believer in that. And, prostate cancer was caught at such an early stage that, he didn't have true complications. We were out to dinner 3 days after he was discharged from the hospital. Even with the catheter, we still went out to dinner. So what is the response in terms of participants, being open to doing PSA screening?
It can vary. A lot of it depends on what that person's exposure to either PSA, urology, or medicine has been. We still deal with a lot of mistrust. You're asking Black people to give their blood, and the first thing they say is, "You're not going to Tuskegee me."
Oh my good, really?
Yes. I'm only about 2-3 hours from Tuskegee where I'm at, so I hear it a lot.
Oh, wow.
But it's, Tuskegee has done a lot of damage. And there's so much good that we can do with having more information, with being able to get this testing, and again, I come from a sales background. You just try to put it within, you try to personalize it. Because really that's what we're talking about. We're talking about one man's PSA.
Right.
And, I had one patient tell me, I don't want to be a guinea pig. And I told him, I said, well, sir, some of those guinea pigs are doing really, really well.
Right.
So it's called clinical trials. We need those. This is how we learn what works and what doesn't work. And because we don't have participation from certain groups, we don't have answers for certain groups. And so all of those conversations, I think, are able to come out. We were able to talk about this in Chicago. They're all tied. They're all tied together. And a lot of it is if I had to boil it down to 2 words, I'd say one is trust and the other 2 is relationship. Mm-hmm. And so my goal is to try to develop the relationships where we can build the trust, and then we can move forward. So the response varies. I had one man who had been diagnosed, and he just said, no, I'm going to go pray about it.
Oh, wow.
And he showed up to get his blood drawn, and one of my volunteers are always extremely well trained. I educate them before we even come into the space. Mm-hmm. And they said, this man's already been diagnosed. He doesn't need a PSA. And so I pulled him to the side. I said, brother, when were you diagnosed? Oh, a year ago. What did I have? Oh, they told me I had intermediate disease. I said, brother, you didn't follow up? He didn't follow up. because he didn't have any trust in what was going on. He didn't believe it. He didn't want to believe it, didn't want to face it. And so even in the screenings and those events, we're going to catch some things that absolutely need to be discussed. Every once in a while, you'll get somebody who just wants to check, but they don't want to get their blood drawn, but that's not common. Most of the time. So I train my volunteers for those events on how to win a patient.
Okay.
Not manipulate, but how to win a patient, how to tell them what are the numbers, what are the data, how to read and say, okay, is this a numbers person, or is this a person I need to give an anecdote, or is this a person you just give the facts? How do you read that before you even start that conversation? Because you have to deliver that information in a way that's palatable. Otherwise, you're not going to get anywhere because you've probably got 1 minute. So it's generally received well. Those who typically show up come there with the anticipation of drawing their blood. You do get a few that are curious that don't. But
thank you for listening to this episode with Dr. John McGill of Phoebe Urology in Albany, Georgia. Make sure that you join our next episode where Dr. McGill will discuss prostate cancer Gleason scores, active surveillance, and surgery. Find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Ellen Shea an email, LandShay@prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, @prostatecancerrealtalk.com.